It's time for a Puscast, the last Puscast of 2019, covering the first 2 weeks of December in the year 2019. References, as always, are available at edgydoc.com, where you will find links to my multimedia empire of books and apps and lions and tigers and bears, oh my. Before we move on to the literature, I would like to wish all my listeners a generic, non-denominational seasonal greeting. First up is a hodgepodge of antibiotic-related papers. There is, by the way, a nice review of penicillin allergy in the New England Journal of Medicine this week. I commend it to your reading if you're short on Ambien. 2 negative studies, and I usually do not report on negative studies, but there's always this question of an association between antibiotics or infectious diseases and subsequent neurologic issues. One study found that the use of antibiotics in the first year of life was not associated with subsequent ADHD. The other looked at the association with seropositivity with toxoplasma, EBV, HSV, and CMV with new onset of depressive and anxiety disorders and found no relationship. And while there are other epidemiologic studies to suggest some infections are associated with, say, schizophrenia or bad driving, as in the case of toxoplasmosis, this was at least negative for these infections and some common mental health issues. If you have spent any amount of time in the scam world, supplements, complementary, and alternative medicine, as I did in my decade over at science-based medicine, you'll recognize that is a popular form of, quote, research, unquote, to see if various and sundry natural or alternative products have activity against bacteria. This is usually accompanied by a famous, at least in the skeptical world, cartoon of someone aiming a gun at a petri dish saying, "Look, this kills bacteria." These are fundamentally stupid research projects because they fail to differentiate often between the importance of antibiotics, which you can give parenterally or orally, and antiseptics, which just kill bacteria. And many things on the planet are toxic to bacteria, but you would not want to apply them to human beings. This is a, quote, major article. They seem to do that a lot in the IDSA world. And some amazing amounts of fetid dingoes' kidneys are labeled as a major article. This one doesn't even rise to the level of Lance Corporal. They looked at the in vitro activity of various essential oils against bacteria and found quelle surprise, bacteria are often killed by products found in nature. Some of the many antiseptics found in the wild and of zero clinical utility or use in the future, as best I can tell. And they conclude, quote, essential oils can inhibit growth of a broad range of pathogens correlating to their presence in aromatic plants. It showed significant in vitro activity against clinical isolates, including multi-drug resistant pathogens and CRE. Further study of the clinical activity of essential oils is warranted. No, it's not. Although it might be fun to go to the liquor store and buy a variety of spirits and then test them against bacteria and show how essential alcohols, such as vodka, rum, whiskey, can kill a wide variety of pathogenic organisms, including resistant organisms. And the fundamental conclusion should be BFD. And really, the IDSA really needs to stop labeling crap articles as major articles. They're not. They just paid to get them published in your journal. Now, personally, I love the smells of stale urine, unwashed patients, and the cries of the demented. So this particular study really surprised me. They did a survey of patients receiving outpatient antibiotics and found that patients preferred home antibiotic therapy over going to a sniff. That is also a major article. I'm going to see if I can publish an article that delineates the fact that water is wet and fire is hot. Don't worry, there are going to be some articles coming up that actually have clinical relevance and are interesting to the practice of infectious diseases, but I just can't help it with some of these. Although they sound the same at some level, they are different. There's severe fever with thrombocytopenia syndrome, which is found in China, is spread by a tick bite, and can be spread person to person. It is due to the SFTS virus. And then there is the hemorrhagic fever with renal syndrome that's caused by hantaviruses and tends to be spread by mice. They are different diseases and have different outcomes, and both are prevalent in China. Can you tell the difference clinically? Not really, at least to be judged from this article, which warrants a brief report instead of a major article. Although it was more likely to be severe fever with thrombocytopenia if there was concomitant lymphadenopathy, low back pain, and a rash. But my take home from this article is that there's enough significant clinical overlap in the syndromes that you can never say with assurance that patients have one or the other of these viral illnesses. Although we have a kidney transplant program at one of my hospitals, I've always been surprised at the lack of infections that we see in this population. This study looked at the incidence of both early and late adenoviral infections in kidney transplants and found that it generally involved the GU system and was associated with allograft dysfunction. Patients were often treated with cidofovir and decrease in their immunosuppressives with overall good results. But hemorrhagic cystitis from adenovirus is on the list of diseases you can see post-kidney transplant, and I don't believe I've ever seen a case. And I can't remember the last time I gave anyone cidofovir, though that may be more a function of my mental capacity than it is of the diseases I see. And a brief reminder, this is a report of the disease in Brazil, but Zika virus is associated not only with congenital neurologic problems such as microcephaly, it also can cause Guillain-Barré syndrome. And during the Brazil outbreak of the disease, there was an increase in this syndrome in the adult population. And another study to remind you that Zika virus can remain in the semen for a prolonged period of time after infection, easily up to 60% of the time at 6 months. And it's more frequent in patients who had eye pain, arthralgias, and high antibody levels to Zika. It has also been found after the infection in a variety of other bodily fluids, including, albeit rarely in all cases, saliva, urine, and breast milk. The final one in 2 out of 168 cases. A pair of HIV articles, one confirming again that having low levels of HIV viremia, less than 200 copies per mil but still detectable, is associated with long-term biologic failure. The goal of treatment should be non-detectable, if possible. They had a variety of risks for having continued low-level HIV viremia, including being African American, prior use of 1 or 2 antiretrovirals, and having a delay in the start of your antiretrovirals. But there's also, in another report out of the MMWR, another reason patients could have low-level viremia, and that is with HIV patients, 7% of patients are not adherent with their medications because they can't afford them and so are not buying them, while others are skipping doses or taking smaller amounts of their medication to stretch out their usage. It's been appalling in the United States that there have been a number of deaths in diabetics because they can't afford their insulin and are doing similar maneuvers to stretch out the medication they cannot afford. You can add HIV meds to that list. If you're an insulin-using HIV positive patient, you're probably as good as dead. I always say that the healthcare in the United States is second to none because we're 50th? And in an interesting drug interaction, they looked at tenofovir concentrations in transgender females, because it turns out that feminizing hormone therapy might mess with the medications, and it does. And they found 7-fold lower concentrations of tenofovir in transgender women. And the concentrations were inversely related to estradiol levels. An interesting and practical drug-drug interaction. This study comes out of sub-Saharan Africa, particularly the Côte d'Ivoire. I have a great French accent. But it looked at the ecologic niche of the organism Streptococcus infantarius subspecies infantarius. This is in the Strep bovis group. And it turns out that humans are likely to become a carrier of this organism if they consume predominantly spontaneously fermented dairy products like butter, as well as those that took care of the livestock that produced said products. And as a strep bovis, there is an association between this organism and cancer, although unlike bovis, which is associated with colonic cancer, this one is more often in some series associated with non-colonic GI cancers. And looking on the PubMeds, there are associations between this organism and, say, camel's milk consumption. So it is a zoonosis in part. I always love these various and sundry ecologic niches of organisms. I always find that's part of what makes ID such a curious job. The Lone Star tick. It probably carries bourbon virus, rickettsia, heartland virus, tularemia, tick-associated rash illness, ehrlichiosis, red meat allergy. Is often found most commonly in the area right around Long Island, but its range is expanding out of its traditional areas for a variety of reasons, one being perhaps reforestation, another perhaps being climate change, and longer, warmer seasons will lead to a more prolonged tick season. This was all pointed out in a nice editorial in the New England Journal of Medicine, but this is not an issue that is isolated to the Lone Star tick, and many infections from Babesia to Borrelia are expanding their range and their season of infectivity, and so all the old rules about who's at risk for infection are no longer quite as applicable as they used to be. That being said, there's still no Lyme in the Great Pacific Northwest worth talking about yet. So this was a very interesting article, and if you're an infectious disease doctor or take care of vertebral osteo, you might want to download this one and share it with your radiology colleagues. It's called Management of Vertebral Osteomyelitis over an 8-year period, the UD-PROVE Udine Protocol on Vertebral Osteomyelitis study. This study was out of Italy, so in one characteristic, it does not apply to anything I can do in the United States. They followed their patients with PET CTs to see both the diagnosis and resolution of diagnosis. And there's no way in hell you can get a PET scan ordered and approved in the United States for anything but malignancy. I've tried and succeeded on rare occasions, but even though it's a great test for infectious diseases, it ain't reimbursed. Second to none, remember? Nonsense. But it was how they diagnosed the infecting organisms. First, everybody was off antibiotics for 2 weeks. Then, when they did the biopsy, they put an aliquot into an aerobic blood culture bottle, an aliquot into an anaerobic blood culture bottle, and an aliquot into sodium chloride solution. Then, right after the vertebral biopsy, even in the absence of fever, they obtained 3 sets of blood cultures, figuring that the process of doing the biopsy would stir up the bacteria, leading to a transient bacteremia. And it worked. They found the infecting organism 75% of the time. That is double the usual yield rate of a biopsy for vertebral osteo, which is reported at around 40%, And I would say it's half that at best in the real world. There are those studies that show having the infecting organism for vertebral osteomyelitis improves outcomes, and it is often difficult to find a neurosurgeon who will do an open biopsy. They always seem to say, oh, just go with medical therapy, your best guess, and see what happens. I hate doing that. And so while I can't get a PET scan in these patients, at least and expect it to be reimbursed, certainly this is a game changer when it comes to optimizing the obtaining of specimens for the microbiologic diagnosis of vertebral osteomyelitis. I've already sent copies of this to my IR radiologists, and I suggest that you do the same, unless, of course, you're already following that procedure. Whether we will ever have a healthcare system that allows optimal treatment of our sick patients remains to be seen, but I am personally not optimistic. So I won't be getting PET scans anytime soon. We have oral phosphomycin in the United States, which comes in the ever so cute formulation of a sachet. We don't have IV phosphomycin, although it is used in that formulation in Europe with good effect. The problem you can often have with diseases like pyelonephritis or other gram-negative rod infections is that phosphomycin does not have good bioavailability, and its only use is for urinary tract infections, and there have been successful trials for chronic prostatitis, giving it for 6 or 8 weeks. But otherwise, its pharmacokinetics stink if you want to use it for other serious resistant bacterial infections. They are now trying a formulation of intravenous phosphomycin in the United States for approval, and in this study showed that it was effective for treating complicated urinary tract infections, including acute pyelonephritis. It would be nice to have IV phosphomycin approved in the United States, not so much for pyelo, but for other resistant gram-negative infections and some gram-positives where it has been shown over the years in Europe to be quite effective. Figuring out the cause of an infectious disease is always a exposure history. Where have you been? What have you eaten? With whom have you had sex? Etc., etc. But it also determines resistance. And as you probably know, if you're an ID doc, different parts of the world have different rates of resistance for different organisms. Here in the Great Pacific Northwest, I have not been plagued by resistant Acinetobacters, although they do occur. And it's important to remember that colistin resistance is different depending on where the patient comes from. It is, for example, highest in Lebanon, not much of an issue here in the Great Pacific Northwest, but China, where we see a lot of people going back and forth from China. And the lowest colistin rates for Acinetobacter are in Germany. But it's 12% in China, which is pretty depressing. And again, a little epidemiology of disease. This concerns the distribution of melioidosis in Thailand. And if you're going to be wandering around Thailand, the worst place to get exposed to melioidosis is in the northeast. And out of 7,000 plus cases of that disease, 5,475 came from the northeast part of the country. I'm always deeply surprised by clinical trials that show that when you involve somebody who knows what the hell they are doing, you get better outcomes in patient care. I never thought that would be the case. Yet another study to show that an infectious disease formal consultation, as opposed to a curbside, is associated with better outcomes in patients with MSSA bacteremia. In this study, it reduced the risk for recurrent bacteremia, and patients did better for up to 10 years. Although I have to admit, I don't believe that the benefit of an ID consultation will last that long. But it remains a consistent trend. Infectious disease consultation for a wide variety of infectious diseases, from candidemia to bacteremia to ICU infections, is associated with a variety of improved outcomes. So when you have patients with Staph aureus bacteremia, you're supposed to recheck the blood cultures at 48 to 72 hours. Because if they remain positive, then you more likely have a complicated Staph aureus bacteremia i.e. endocarditis. And if those repeat blood cultures are negative, you breathe a sigh of relief and you proceed with the PICC line with the negative cultures, reassuring you that you can do so safely. But can you? This study looked at a positive, or in this case negative, blood cultures in patients with staph bacteremia, and they found that in 13% of the time with staph bacteremia, the bacteremia was intermittent, so you'd have a negative culture followed later by a positive culture. Which then begs the question, just how many blood cultures should you get in a patient with staph bacteremia who has a negative blood culture? But it goes really to the heart of the matter that determining whether or not Staph aureus bacteremia is complicated or uncomplicated is difficult. And you should probably err on the side of overtreating rather than undertreating Staph aureus bacteremia. But then that is why you get infectious diseases involved, right? But no matter how you slice it, Staph aureus bacteremia is a confusing and difficult medical problem. Most people are aware that salmonella is found in reptiles and in turtles. When I was a fellow in Los Angeles, we had several cases of salmonella bacteremia in cancer patients who were taking rattlesnake pills. They would grind up whole raw rattlesnake, convert them into pills, and take them as a cure for cancer and AIDS. It didn't work. But this study looked at the presence of salmonella species in venomous snakes, nothing that people usually carry about with them unless they're working in some peculiar Christian sects that like to handle venomous snakes. And they do found that they have a variety of salmonella in that group as well, including those that are pathogens in human beings. So if you're going to be handling venomous snakes in any time soon, not only be wary of the bite, but be wary of salmonella. Thinking about it, I don't think I have ever seen a case of Vibrio vulnificans, a cause of hemorrhagic bullae and sepsis in patients with liver disease. I suppose with global warming, we may start to see that here in the Great Pacific Northwest. I presume that our water has been too cold for most Vibrio species. There is some New England Journal articles that have shown that other Vibrio species are increasing in the Great Pacific Northwest as the world warms. Wasn't that a soap opera back in the day? Anyway, what is the best treatment for Vibrio vulnificans? It has long been said that the treatment of choice is a combination of a third-generation cephalosporin and a tetracycline. This study out of Korea found that combining a third-generation cephalosporin and a quinolone was not inferior to the standard third-generation and doxycycline. And although it did not show statistical significance, I think it's interesting that the combination of a third-generation cephalosporin plus a quinolone had the lowest mortality rates. And again, the issue of survival with unusual infections. This study looked at the mortality in patients with enterococcal bloodstream infections and the effective management of a bundle in working with these patients. And they found that those who received the bundle for the treatment of enterococcal bacteremia had better outcomes. But what exactly was this bundle? First was an ID consultation, which was probably key in outcomes. As I've said before, getting people involved with patient care who know what the hell they are doing is usually of benefit. Then decisions were made as to whether or not the patient should get echocardiography, and appropriate antibiotics were given sooner rather than later with this particular intervention. The other, and I think kind of peculiar intervention, was to get blood cultures every 48 hours until you had negative results. I personally don't see the point in doing that. Getting the first set, yeah, I see that. Getting follow-up, well, actually, I see that, because the differentiation between endocarditis and not endocarditis is usually a sustained bacteremia. But after they're positive, I don't see any real reason to keep getting blood cultures except to satisfy the PICC team that they can safely put a PICC line in the patient to treat their presumptive endocarditis. I still think we get way too many damn blood cultures in patients. But the key intervention, I suspect, in this particular trial was getting an informed infectious disease consultant who could help differentiate the optimal therapy and know what to look for the complications of enterococcal bacteremia. Pneumovax recommendations have changed of late. Everyone who's an adult greater than 65 should receive the 23-valent, the old school Pneumovax, but should they receive the 13-valent child's vaccine? And now, if you don't have an immunocompromising condition, CSF leak, or cochlear implant, because invasive disease is so rare thanks to vaccination of children, it's now no longer recommended to receive routinely, but part of a discussion between you and your patient as to whether or not they should receive the vaccine, what they call shared clinical decision making, which I think is a myth. I mean, there's no way that your patient is going to understand the ins and outs of vaccination and whether or not they should receive one. And of course, it will get down to how the prescribing physician will discuss the data that will lead to the patient's decision as to whether or not to get the vaccine. I consider that somewhat to be a cop-out. We all know that how you discuss a given process with the patient will often determine what decisions they make. And to say that there's shared decision-making is an abrogation of the responsibility of the physician. But the vaccine certainly does work well in children, and there was a study to show that since the introduction of the 13-valent vaccine in kids, there's been a marked decrease in otitis media in children under the age of 2. Another major article in Open Forum Infectious Diseases, a study by the pharmaceutical company that makes iridovancin that suggests that, hey, iridovancin is better than vancomycin. Wow, what a surprising outcome. The vast majority of these patients had cellulitis, and they received either vancomycin, the vast majority, or iridovancin, a minority. 120 patients who received iridovancin were compared to 6,695 patients who received vancomycin for their soft tissue infections. There was a hodgepodge of infections, but as I mentioned, the majority of patients had cellulitis. Patients had the same cost, but there was a decrease in 30-day admission rate. And so the makers of iridovancin suggested that, hey, iridovancin works. But the problem with this study, and this is what you cannot tell from the data, is they really do not have what the infecting organism was. The article does state that, quote, therapies often require the use of 2 different oral antibiotics to cover all suspected pathogens, and many oral therapies are dosed several times a day. Really, what the hell's going on with the treatment of cellulitis? It's always group A strep, sometimes group G strep. Everybody needs a couple doses of cefazolin, then out the door on oral amoxicillin. How hard is it? Every one of these studies seems to be unneeded antibiotics given for unlikely pathogens. In my hospital systems, we have worked very hard to make sure that everybody admitted with cellulitis gets cefazolin, although the pharmacists are insisting upon cefazolin, and we've done follow-up carefully, and we're not seeing readmissions, and we're not seeing problems, and everybody's doing just peachy keen, and they're avoiding vancomycin and iridovancin and all these other antibiotics. Cellulitis comes in, they get cefazolin, and they're sent out on amoxicillin, and it's working great. It's amazing the BS that gets done in acute soft tissue infections. One of the common outpatient consultations I get is positive quantiferons in patients who are going to be receiving biologics like TNF inhibitors. What is the risk for someone to develop tuberculosis under these circumstances? This study of 5,800 rheumatic patients found that those who were positive for TB had an 18-fold higher risk of developing TB on therapy, which is pretty amazing. And the number often needed to tell patients that even in those who received treatment for latent TB, little under 3% went on to develop tuberculosis as well. although this study was out of Brazil, and you don't know whether this was reactivation disease or, given the endemicity of tuberculosis in Brazil, it was new acquisition of tuberculosis. And it is interesting that not all biologics were created equal. I'm about to butcher these names, but the drugs adalimumab and certolizumab were associated with, quote, greater and earlier TB diagnosis compared to etanercept. When I was in training, there was one coccidioides, one histoplasmosis, one paracoxy. All these fungi were considered a single entity. Now I know that there are multiple coccidioidomycoses. There's also multiple histoplasma, and it's important to know that histoplasmosis is worldwide in distribution. This article shows that it is an issue in China, and there are parts of China where histoplasmosis is endemic. Also, paracoxy is a variety of organisms, and one of them goes by the name Paracoxylucii, and it clinically looks all the world like P. brasiliensis. This particular organism is found predominantly in the Mato Grosso area of Brazil. But as you would expect on basic evolution, those organisms that are isolated tend to evolve into their own subspecies. And that's certainly true of all the fungi that I learned as a fellow, which were all thought to be just one bug. Remember Angiostrongyloides? It causes eosinophilic meningitis. It is the rat lungworm. And generally, you acquire it by eating slugs that have been in contact with rat poop. You may not think, I want to eat slugs, but people sometimes eat slugs by mistake when it's in your salad, or they eat them deliberately because, hey, slugs. I remember as a 2-year-old, my eldest scooped up a slug and popped it in his mouth before I could stop him. And it's also found in Hawaii, where, quote, 80% had seen snails or slugs on their property, and 67% had observed rats or rat dropping, and 64% reported eating unwashed produce. Yet another reason, as if it were needed, to only eat deep fried food, or at least avoiding eating snails and rat shit. Who would have thought that would be needed advice? Again, the content of this Puscast is either things I think are of interest, things that are practical, or things that are cool. This is in the last category. Trichomonas vaginalis has a virus, the Trichomonas vaginitis virus, and it infects Trichomonas. It turns out this makes no difference clinically in patients, that if you had T. vaginalis virus in your trichinosis, which occurred 40% of the time, there was no difference in your clinical symptoms. But I just think it's cool that this organism has its own virus that infects it. Again, I was always taught that Plasmodium vivax and Plasmodium ovale tended to recur. And they recurred because they have a liver phase. And that's why you give them Primaquine. And that is what I was taught. Now, I don't see a lot of malaria here in the Great Pacific Northwest, so I've never really dug deeply into that particular issue. This was interesting. They looked at whether or not it was true that P. ovale will recur. Evidently, there is data to show that P. vivax does, and that the liver is the reason. But is that true for P. ovale? So they looked at people who got treated for Plasmodium ovale, and it recurred sometimes. It turns out, and I knew this, that Plasmodium ovale has two different subspecies, as it were, P. ovale curtisi and P. ovale wallicheri, if I'm pronouncing those correctly. These things do not come trippingly off my tongue. And there was a difference. For the first time, it was proved in a clinical trial that P. ovale does recur after treatment and clearing the blood. But, and here's what was interesting, the reappearance occurred with curtisi, but not with wallicheri. assuming I pronounced those right. So while these organisms are morphologically the same and genetically different, they can't mate, they may have a different life cycle depending on which P ovale they are. And I think that's cool. And lastly, there's a nice review in Clinical Infectious Diseases of our soldiers as vectors of infectious diseases. Our soldiers are often not immune to endemic illnesses, so when they travel to other countries, they will acquire infections and then potentially bring them back to the United States. I usually think of children as great vectors of infections, but our soldiers have acquired a variety of interesting diseases over the years and brought them home. And that ends this Puscast, a review of the infectious disease literature for the first 2 weeks of December in the year 2019. References are available at edgydoc.com, home of my multimedia empire. And otherwise, I wish you all a generic, non-denominational seasonal greeting. The next podcast will occur sometime in the new year of 2020. As always, thank you for this most interesting consultation and allowing me to participate in the care of this most difficult and challenging case. I shall continue to follow along with you. Thank you. In dictation, and take it away, Jeff.